Hi, everybody. This lecture is on ear, nose, and throat disorders. So typically, we talk about disorders of the ear from the external ear structures right on through to the middle ear and to the inner ear. And this is just a description, or I'm sorry, this is just a picture of the anatomy of the ear with all of the typical structures. The first most common thing that you're going to see in the adult population is patients with hearing loss. The main types of hearing loss are conductive, sensory, and neural. A conductive loss is just as it sounds, that there's problems with sound being conducted through the tympanic membrane. The most common reason for this is usually cerumen impaction, but middle ear effusions and eustachian tube dysfunction can also be causes of a conductive hearing loss. The other common thing that happens in the adult population is that they tend to have a loss of high frequency tone, and this is more from long-term excessive noise exposure. It can be head trauma, or it can just be a normal sensory deficit from aging. It's called presbycusis. For the neural reasons for hearing loss, it's usually lesions that involve the eighth nerve, the auditory nuclei, or the auditory cortex. So the most important thing is for you to be familiar with the assessment tools that help diagnose hearing loss, the whisper test, the Weber and the Rene testing, all those things that you learned in 619. It's important for you to get the Bates book out and possibly refresh yourself with those types of assessment. Another more common condition of the ear disorders is external otitis media. It typically presents with rapid onset of ear pain, tenderness, itching, oral fullness, and hearing loss. And more times people will say that they have a discharge or something watery coming from their ear. The more common causative agents of this is a gram-negative, the Pseudomonas, and the staph species, and at times it can be fungi-related as well. We see otitis externa a lot of times in humid weather, people who are doing a lot of swimming. We see a lot of times now with all of the earbuds that people wear that there's a lot of incidence of otitis externa in that population. Typically, this grows in excessive moisture. The treatment is to avoid excess moisture to the ear, so no swimming, no blocking the ear with earbuds, etc. A neomycin polymyxin ophthalmic drop, 1 to 2 drops to the affected ear 4 to 6 times a day for 10 days. Or you can also use a ciprofloxacin dexamethasone otic solution, and that's 4 drops to the affected ear twice a day for 10 days. If there's excessive redness and cellulitis around the periauricular tissue, then you might want to think also about using fluoroquinolones. Here's a picture of an otitis externa. You can see that this is the ear canal that we're looking at in this picture with the tympanic membrane here in this area. And what you're seeing is a lot of white exudate and debris, which is typically not there in a normal ear structure. Acute otitis media is also something that you'll see in the adult population. If you've gone to the peds rotation, I'm sure you'll see it a little bit more often there just because of the anatomy of the ear in the pediatric patient. Patients usually have otalgia and it's often associated with an upper respiratory infection. They have erythema and hypomobility of the tympanic membrane. The most common pathogens are the staph pneumoniae, the Haemophilus influenza, and the Streptococcus pyogenes. The treatment is amoxicillin or erythromycin plus a sulfonamide for 10 days. Other options, is the cefaclor or the amoxicillin clavulanic acid combination found in Augmentin. Typically for these kinds of disorders where you need to prescribe a antibiotic, it might be well worth it for you to invest in Epocrates if you have a smartphone, or to look at buying the Sanford Guide, which gives you the most up-to-date antibacterial agent to cover some of the more common conditions. Here is a couple of pictures of otitis media. You can see up here on the left, the picture is shiny. There's a lot of hypomobility, and the tympanic membrane itself is red and bulging. On the picture on the bottom, you can see that there is a lot of hypomobility in this eardrum, and it's retracted, and there is redness. Disorders of the sinuses is another common thing that you're going to see, especially this time of year. The reason that we do the eye disorders and the ears, nose, and throat disorders and sinuses is because you're going to see that a lot of time this year. A lot of these conditions this time of year. So as far as conditions of the sinuses, viral rhinitis is one of the more common ones. It's caused by the rhinovirus or the adenovirus. It can lead to otitis media and sinusitis if it's left untreated. It's usually self-limited, and you usually treat this with over-the-counter remedies. Typically, now they have a lot of the Flonase and the Nasocort nasal sprays, which are steroid nasal sprays. But, I think one of the best standby remedies that's more homeopathic is just a saline nasal spray that keeps your sinuses draining and keeps things moving. In acute sinusitis, the definition is characterized by an impaired mucociliary clearance and obstruction of the osteomeatal complex. The typical pathogens are strep pneumoniae, other strep strains, H. flu, Staph aureus, and MCAT. The maxillary sinuses are usually the most commonly affected, and signs and symptoms in particular are unilateral pain. They don't have pain across both of their sinuses. That's typically more a allergy or a viral cause. But when people have bacterial sinusitis, it's usually one side. They have purulent nasal discharge. Sometimes they get bloody noses. Sometimes they just can have just thick, purulent discharge. They say their teeth hurt. You might notice that they have bad breath. They can't smell anything, and it usually follows an upper respiratory infection 10 days preceding it. One of the classic things about sinusitis is patients will say, "Oh, I had a cold about a week ago, and it was getting better, and now all of a sudden the past couple of days it seems to be getting worse again." It's a very common hallmark complaint from the patient. If patients have problems with ethmoid sinuses, they're going to have high lateral sinus wall pain. It's usually between their eyes or behind their eyes. If it's in the sphenoid, it's usually a headache in the middle of the head. Frontal, obviously, is the tender forehead. And typically for sinusitis, a long time ago, they used to do x-rays, plain films of the sinuses to look for air fluid levels. But the research has shown that that doesn't really yield a better diagnosis. We don't use plain films anymore, and we only use CT scans if the patient doesn't respond to antibiotic treatment. The treatment includes a decongestant, typically up to 240 milligrams a day, and this is the Sudafed or the pseudoephedrine, and this is the Sudafed that the patient has to sign show their license and sign for. This is not the pseudoephedrine that is on the counter that you can just buy over the counter. Amoxicillin is usually the first line of treatment, and then macrolides are the second line. For the amoxicillin, it's usually at least 1,000 milligrams twice a day as opposed to the 500 milligrams TID because it's hard to infiltrate that sinus cavity with just a smaller dose of antibiotics. And with all of the penicillin resistance that's going on, you really need to make sure that you have a higher dose in order to infiltrate that sinus cavity. Typically, or most often, treatment has to be for at least 10 days. The ear, nose, and throat people would probably prefer 14 days. For multi-drug resistant strep pneumoniae, they might need a beta-lactam inhibitor like amoxicillin with clavulanic acid, which is the augmentin, and also a cephalosporin might be an excellent choice for sinusitis. We typically like to reserve the fluoroquinolones as a last resort. And if patients have sinusitis that goes untreated, they can develop an orbital cellulitis, an osteomyelitis. Sometimes the infection can extend into the intracranial cavernous and cause a cavernous sinus thrombosis. If patients have any ocular findings, if they start to have an exophthalmos, if they start to have a lot of eye pain, and they have also sinus symptoms, it would warrant a CAT scan of the sinuses to make sure that they don't have any of those conditions. If a patient goes on an antibiotic and typically doesn't do well or says that they're not feeling better and they try a second antibiotic and they're still not getting any better, then that's usually when we do the CAT scan. The patient who does not do well or keeps failing antibiotic therapy and isn't getting any better would warrant a referral to an ear, nose, and throat person. And they say here for CAT scans to be done if symptoms are longer than 4 to 12 weeks. But typically, I'll put somebody on an antibiotic for 10 to 14 days. If they felt better and then the pain came back and I put them on another antibiotic and they fail, that's only a 4-week trial. But that's when I will get the CAT scan, unless, of course, there's any kind of orbital symptoms. Patients who've got any kind of eyelid drooping, visual changes, mental status changes, or have a lot of facial swelling should probably be considered for antibiotics. And this page 215 is from the current, I think, 2014. So around page 215, you can find the most recent antibiotic recommendations. And again, like I just said before, you can look at Hippocrates, Up to Date, and the Sanford Guide. Allergic rhinitis affects 14 to 40% of Americans. Is typically caused by exposure to airborne pollens and spores. The symptoms of hay fever are eye irritation, itchiness, excessive tearing, and the physical exam usually shows some thickened mucosa in the turbinates. You're going to see a lot of allergic rhinitis, especially in May and April around this area because of all of the allergens that are around our communities. The treatment is antihistamines, intranasal corticosteroids like the Flonase, the Nasacort. And if patients don't do well on antihistamines like Zyrtec, Claritin, Allegra, and you've done also the intranasal corticosteroids, you might want to think about an anti-leukotriene medication, excuse me, like Singulair, which you can add on to those other medications. The next condition that I want to talk about is oral candidiasis. Typically, this is otherwise known as thrush, and it's an overgrowth of bacteria in the posterior pharynx. This is typically brought on when patients have been on antibiotics for long periods of time, if they've been on inhalers and they have not rinsed their mouth out, especially with the steroid inhalers. If they're immunocompromised, you can see a lot of thrush in those types of patients. They have white patches with an overlay of erythematous mucosa. So typically what happens is they have a sore throat or they'll complain of a sore throat. And if you look at their throat, you'll see a lot of white patches. And you might at first be confusing it with some type of sore throat or tonsillitis like we've talked about in the other lectures. But these patients typically aren't sick with cold symptoms. We might see them in people who wear dentures, like I said, who are immunosuppressed, if they're diabetic, if they have poor hygiene, if they're anemic, or they've been on chemotherapy that makes them immunosuppressed. And also if they've been on steroids or have had recent antibiotics. The treatment is usually a nystatin, swish and swallow, or swish and spit. It's 5 milliliters PO 4 times a day for 14 days. Or you can try what's called the Miselex troches, or the clotrimazole troches, and that's 1 lozenge 5 times a day for 14 days. And typically, if that doesn't go away, or if they get just a little bit better but not all the way, then you would think about putting them on a diflucan once a day for 7 days to see if that doesn't help. Peritonsillar abscess is a condition that we've talked in the other lecture for pharyngitis, but I want to go over it again. Here, it's like we had talked about trismus and medial deviation of the soft palate. They have that muffled voice or that hot potato voice. The abscess is always unilateral, and you're going to treat it with an antibiotic versus an IND, and they typically need referral to an ear, nose, and throat. Here's another picture of a peritonsillar abscess. This person has a left peritonsillar abscess, as you can see. The soft palate is all swollen and erythematous, and it's actually shifted. And here's the abscess itself. And that concludes the lecture on ear, nose, and throat. If you have any questions, please refer back to the current book. And here are some other references. Thanks.